readers. And I think the reason why a lot of us read is so that we can learn from other people's mistakes. And today I have Sean Weiss, who is known as the compliance guy, to share with us some of the lessons that he has taken from other people who have made mistakes and how he has fixed their problems. So I would like to learn from other people's mistakes so I don't make those mistakes. I'm very excited to have Sean on the program. He's been in the healthcare field for over, I think, 25 years. He is a certified compliance officer, certified healthcare compliance officer, medical compliance officer, certified professional coder, payer, and a certified E&M auditor. So I feel a kinship with him because I'm also very passionate about evaluation and management, compliance and accuracy. So thank you so much for joining us, Sean, and welcome to the program.
Thank you. Good morning, Dr. Lynn. It's a pleasure to be here and to be here with all of your viewers and listeners.
And I want to let everyone know, if you have any questions watching the live stream in the Facebook group, please feel free to put them in the comments and I will relay those to Sean. Okay, Sean, as we were talking before the program started, you have had a lot of experience in physicians getting served by these three-letter entities from the government. And would you mind sharing maybe one or two examples of what happened recently?
Yeah, certainly. So again, thank you for allowing me to be here this morning. Yeah, obviously, this is 2021 has really been the year of the audit. And I could tell you and your viewers and listeners that 2022 is going to be the year of the audit on steroids. The FBI has been very active. They engage, obviously, with the Office of the Inspector General, with the U.S. Postal Service, with the Department of Justice, and with the DEA, as well as some other entities. When they believe that information they've been provided, either through a human asset of a governmental agency, or there is somebody that is called a whistleblower, and they've done some preliminary staging, some investigating, they will then get warrants issued, and they will show up to your practice. Had a practice, as we were just talking about, this past week. This is the second one in about a month and a half that's reached out to me as the FBI was in their facility, entered the premises at 8 o'clock in the morning, and they love to do it. Just like you see on TV, sometimes they get a rush out of that. They come in with their guns drawn. They come in very anxious, very loud. They let people know that this is the Federal Bureau of Investigation, or the FBI. Do not touch your phones. Do not touch your computers. Do not get up. Do not move. Do not pass go. Do not collect any money. And in this matter, the provider by 8:20 was taken into custody, was taken down to the federal building, and was arraigned before a judge via a Zoom meeting, very similar to the way that you and I are conversating this morning. And that's pretty much where things are at for that provider. Obviously, they show up with a member from the U.S. Attorney's Office, to make sure that they serve the warrant accordingly, and that they do things, without too much hassle or too many potential mistakes. Had another one up in New Jersey just recently as well. Same thing. This one happened to be a pain management group. Showed up 8 o'clock in the morning. By 8:30 in the morning, the provider was taken into custody, taken down to the federal building in Newark, and was arraigned by, I think, 4 o'clock in the afternoon, if I'm not mistaken. So, as I tell my clients, it doesn't matter whether you're in rural USA or you're in the middle of a metropolis. And it's not a matter of if you get audited or if you get targeted. It's simply a matter of when. So you got to be prepared. You got to dot your I's and cross your T's.
Okay, so that is, wow, I can't even imagine. I mean, to have one of these three-letter agencies come into your medical practice and then take you away, and then your entire staff is probably just, I guess they go for the shock and awe effect. Like, we're here, don't move, don't touch anything, we're taking everything. So I can just imagine in that scenario, the first person I'm going to call is you, because there's nothing, I do a lot of vasectomies, and I will tell patients that experience matters. And for you, who has been dealing with this and dealing with attorneys on the defense side, on the physician side, it is imperative for me to have your number on a speed dial just in case I get audited, when I get audited.
Yeah. And, here's the other thing, too. It's not just these three-letter government agencies that show up at your facility. The commercial payers are doing it with their special investigative units. So you're not immune, or you shouldn't think that you're immune from having somebody show up to your facility from United Healthcare or Optum or Anthem or Humana or, one of these other large commercial insurance companies.
And I think they do these private payers do these audits as chart requests, like mini audits. I think of them as they will request one chart, two chart, few charts, just to kind of look at the trend and then go after you that way. Sean, I'm sure you're aware about the whistleblowers. There are now apparently some private entities, private venture capital entities, to bring up these qui tam lawsuits or claims against providers, physicians, medical offices. That's a new thing that I started reading recently.
Yeah, I actually have a case right now in Florida, actually in Miami, Florida. So the whistleblower, or what they call a relator, happens to be a physician himself. He's not been a practicing physician for many years. What he does is he uses the CMS data files to actually go out and, Google, Bing, and some of these other search engines are a great tool for individuals to be able to identify national provider identifiers, your NPI number, Dr. Lynn, as an example. They find Dr. John Lynn, Arizona urologist. They get your NPI number. They go into the Medicare claims database and they plug in your number and they pull all of the data analytics on your NPI. And then they can use that to say you are an outlier based on your peers for a variety of CPT codes. Never once having looked at any documentation at all, they work with these bottom feeder attorneys. That's the only way I know how to explain them. And I apologize if I'm being too blunt, but they're bottom feeders. And what they do is they file these qui tam cases, as you said, or whistleblower cases all around the country, hoping that the Department of Justice will intervene on their behalf to take on the case, so that if the government intervenes and there's a settlement agreement, or if it does go to trial and there's a guilty verdict, whatever the overall dollar amount that's recouped by the government, they, as a relayer, will get a percentage of that.
And that's why people bring out these claims, is because it's a payday potentially for them. And just mining the database is easy.
Yeah, that's right. It is. And what I tell all of my clients around the country is something very simple. Monitor your utilization. Run your utilization reports. Get programs that are out there like Compliance Risk Analyzer. And again, I have nothing to do with these organizations, but there's a program like CRA. It's called Compliance Risk Analyzer. And basically, you can, on a daily basis, quarterly basis, annual basis, whatever you want to do, you run your utilization reports, you plug that information into their database, which consists of more than, I think, 300,000 providers' claims around the country from these raw data dumps that get put in there from the largest clearinghouses, and then they use your GeoZip, excuse me, and they use claims broken down by specialty taxonomy to be able to help you identify financial risk, aberrant coding patterns, and then it will help you structure, to what you were saying just a moment ago, an audit. To me, any provider that's not at a minimum conducting an annual audit of his or her documentation is being negligent. And negligence is a term that the prosecutors love to use in a charging document or when they're going for an indictment.
Okay, that's a great point. So audit, and also the distribution of outliers and stuff like that. You're in E&M coding. You're deep in E&M coding. What I have heard, and I know this for a fact, that a lot of physicians will undercode to meet whatever the artificial bell curve is. So what they are doing is artificially driving down the distribution of certain E&M codes. And I'm trying to convey to these people that deliberate undercoding is just as wrong and illegal as overcoding. However, I'm sure governmental agencies are not going to come after you, most likely because you're undercoding, because they don't have any financial incentive. It all comes down to money. So they don't have any financial incentive.
Well, actually, believe it or not, it's just the opposite. There's actual case law for groups. Not too long ago, a group was targeted for millions of dollars for what they call systemically undercoding, because what they're doing is they're manipulating the physician distributions that the government relies on.
Yes.
And I'll share something with you that was really interesting, since we're on this topic, if I can. I just came out of a huge federal criminal case in Kentucky and Indiana. It was a 22 count case against this provider.
Wow.
And we were arguing on the defense side, we were arguing the utilization numbers and the statistics that the Department of Justice was putting out there. And I swear to you, I've been doing this, at the end of this year will be 27 years I've been doing this kind of work. I've never, in all my years of casework, have seen the DOJ do this. But they actually came out and they objected to our argument of the statistical numbers that they were presenting. And the lead prosecutor actually said to the judge, "Your Honor, we do not want to use any of the government's data at this point because we've determined that it's unreliable, it's inaccurate, and it's problematic." And the judge looked at them and said, "Wait a minute. You're now telling me you don't want the jury to rely on and for the defense to make an argument about the exact data that you used to indict this provider? Come on." I swear to you, in all my years of doing this work, I've never seen that. And, so yeah, systemic undercoding is highly problematic. It is as problematic as systemic overcoding because you are impacting the distribution of the physician curves, what most people like to call in lay terms a bell curve. So to your point.
Yeah. And, as you know, E&M 2021 has undergone major changes, and we know that a new curve should be developing. And based on historical, the way you see patients, the way we see patients, there's going to be a shift from 213 to most likely 214 if the provider understands how the rules are being applied and used. But we'll see if that actually happens. If there's continued undercoding by the physician because maybe they don't understand the rules, or maybe they just simply want to continue to undercode. And when it comes to risk assessment and risk mitigation, what are your thoughts about a physician or a coder or a practice sending people to different courses on coding and documentation as part of the compliance program?
Yeah. So, for me, I'm all about educating. I'm all about reading and learning. I probably spend 25 to 30 hours a week reading thousands of pages from the Federal Register. Obviously, we just had the release of the CMS proposed 2020 Medicare physician fee schedule, as well as the OPPS proposed rule changes for 2022. Um, yeah, I'm an advocate of sending people for training and education, but think about this under the 7 elements of an OIG compliance program. And for your listeners that don't know what I'm referring to the OIG compliance program for individual and small group physician practices. This is what was released in the Federal Register. If I'm not mistaken, it was volume 65, number 194, from October of 2000. So yeah, I'm a bit of a policy wonk. I'm a policy nerd. That's from all my years of spending time on Capitol Hill. But as part of the 7 elements of a corporate compliance program, the 4th aspect is communication, education, and training on compliance issues. So yes, send your people to well-respected, um, you know, organizations that have a rich history of providing solid content. For me, I have 10 national board certifications in addition to my other education. For me, I rely on groups like HCCA, the Medical Group Management Association, AHIMA, the American Academy of Professional Coders, or AAPC, um, Practice Management Institute, the National Alliance of Medical Auditing Specialists. Those are the organizations for me over my almost 27 years of doing this that I've come to recognize as the gold standards in training and education. And I always hear, if I can, from providers who tell me, Sean, the cost of running a medical practice is outpacing my reimbursement by double digits. You want me to spend more money to send my people for training and education when I'm having a hard time with my reimbursements? And my answer is definitively yes, because now is the time you need to shore up your coding practices. You need to understand the requirements for evaluation and management services. You need to not only mitigate your compliance risk, but you want to mitigate your financial loss risk as well. And that's what, highly educated employees can do for your organization, and as well as improving the morale of your staff. So I'm with you 100%, Dr. Lynn. Educate, educate, educate.
Yeah, and I think that could be part of the compliance program. In my mind, I'm thinking, okay, well, as long as you're sending people to these training courses and implementing these changes or catching up or keeping up with the changes, then you have a program in place. You can hopefully mitigate some of the losses or potential losses due to claims from the government or private payers.
Yeah, absolutely. And, here's the other thing. Since we're talking about compliance programs, your compliance program can't simply be a binder that sits on a shelf. I mean, if you went out and you spent $99.95 on one of these compliance programs where you simply go in and you click replace and you find the word practice or health system or entity, and you put the name of your practice in there and click replace all. And at the very end, it says, congratulations, we made 1,467 changes to the document. And then you print it out, you stick it in a binder, and you never touch it. That is probably the worst thing that an organization can do, because you need it to be what I call a living, breathing document. You've got to create a culture of compliance in your organization in order to thwart the risk of outside entities criticizing and ripping apart your practice. And that's what your policies and procedures are for, your SOPs. You've got to have a living, breathing document. Otherwise, throw it into trash, roll the dice, take your chances, pray you don't have an investigation. And if you do, get your attorney to negotiate as part of your settlement agreement a CIA. It's called a Corporate Integrity Agreement, which is a monitored compliance program by the government. I don't suggest doing that, but for those who don't want to spend the money up front to do it the right way,
And
that's really your option.
And I'm looking at the USA.gov. If you look at the Office of Inspector General's website and you click in the search field, you can search your specialty. I typed in urology, and I'm seeing all these corporate integrity agreements. And believe it or not, a lot of urology practices names and their infractions and the amount that they're paying the government for the alleged wrongdoings, the penalties. It's substantial. I mean, we're talking millions of dollars.
Absolutely. Absolutely. And, here's the thing, Dr. Lin, you get it. And obviously your subscribers, your followers, the members of your group get it, which is why they watch these these interviews and they engage into dialogue. But there's always those providers out there that refuse to hear the message or don't want to believe the message. And urology actually is facing some proposed cuts in reimbursement under the clinical labor aspect of the proposed 2020 rule. And remember, all of us right now in 2022, under the proposed rule released by Medicare for the physician fee schedule, we're looking at a $1.31 cut to the conversion factor from $34 and change down to $33 and some odd change, plus your clinical labor adjustments that are being proposed as well. So we're going to see anywhere from a 1% cut all the way up to a 6% cut for certain specialties. And urology is on that list of specialties that are facing potential cuts. So that's why it's so important, to your point, Dr. Lin. Providers have to understand their CPT coding, the application of modifiers, the critical importance of assigning the most accurate ICD-10 code to support what it is that you're doing. And without taking the time to educate yourself, you're just asking for people to come and audit you.
And the way I think of it is, Sean, we like to, everybody loves to complain, and the docs are saying, well, you know what, I went to medical school, I spent all this time trying to do medicine the best as I can, and now I have to learn this new language, these new rules. And my thinking is, okay, fine. If you don't want it, if you don't want to follow these rules, great. Opt out of Medicare.
Yeah,
right?
But to the point that we were talking about before, the commercial insurance companies.
Or no, I'm talking about opt out of all payers. I mean, go okay. Cash. If you don't want to follow these rules, nobody's forcing you to, right?
Yeah, I think that works in certain geozips, right, where you have a level of affluence, where you have individuals who, yeah, going cash pay is really difficult. I have a lot of clients that have entered into concierge medicine, or they're doing a cash practice. And, for them, they were in business for 10, 15, 20 years. They were maybe around longer during the 80s Mercedes, and they were doing well. And they're at the point where for them now, it's not about how much money can I make. It's about continuing to practice, doing what they love to do, taking care of patients, and they're willing to have a smaller patient population because, they've made their money and they feel like, look, I don't need the hassle of the government or these insurance companies anymore.
Yeah.
That's maybe 1% of the physician population.
Yeah.
I just don't see how providers could opt out of these insurance companies and expect to survive.
It's going to be tough because we're so used to it. The general public is so used to it, and any minor changes, even with for instance, the high deductible health plans, which pretty much everyone has, those small changes they're difficult for the general public to swallow. And I can't imagine switching to cash pay. It's going to be pretty tough. So that means if you want to continue to play, I like to call this the game with Medicare and private payers, unfortunately, you have to follow the rules.
Agreed.
Yeah. So, what are some other risk mitigation strategies other than having a robust compliance process, not a binder, but a process? Do you have for us?
Yeah. So obviously, we've talked about a couple of things, right? Obviously, communications, education, training on a continuous basis, so important. Um, you know, for me, I think it comes down to recognizing the importance of, you know, looking at healthcare as a business, right? That's why we call it the business of medicine. And unfortunately, you know, the clinical aspect of medicine does not always align with the business of medicine. They tend to bang heads. For me, the things that I would recommend are, looking at guidance documents that are produced by the government. One of my favorite documents to talk about is something called the U.S. Department of Justice Criminal Division Evaluation of Corporate Compliance Programs. For me, this document came out a few years ago and it's undergone some changes. And it was really interesting. In 2020, because of COVID, the DOJ kind of snuck it under the radar because they made some significant changes. And for me, I refer to this document as the DOJ's playbook, right? Because in this document, what they're talking about are the principles of federal prosecution of business organizations and hospitals, health systems, physician practices. We are businesses, we are business organizations. So we underwent a change from what used to be called the USAM, the United States Attorney's Manual, and it's now referred to as just the Justice Manual. And um, what they talk about in this Justice Manual are methodologies, and they describe the factors, if you will, that prosecutors need to consider in conducting an investigation of an organization, um, in helping them to determine whether to bring charges and negotiate plea or other arrangements. And these factors that we're talking about include the adequacy and effectiveness of the corporation's compliance program. But listen to this: at the time of the offense, but also as well at the time of a charging decision, and a corporation's remedial efforts to implement an adequate and effective corporate compliance program or to improve upon an existing one. So for me, yes, conducting audits are important, but remember, conducting audits is just a small portion of your overall compliance program. We need to have effective policies and procedures for documentation requirements. And especially now with the changes to the 2021 E&M documentation guidelines, the way we document in the medical practice versus how we document in the hospital or other settings could be inherently different, right? Because in the office setting, right now, we're talking about selecting levels of service based on time or medical decision making, but they have to be in concert with or in conjunction with medical necessity, right? Because medical necessity is still the overarching criteria in addition to the individual elements of a CPT code. But in a hospital setting, we can still rely on the individual elements, right, of the history of present illness, review of systems, past family social history. We can rely on the objective aspect of our documentation, the physical examination, and then the elements of the medical decision making. So for me, it's not just about having a corporate compliance program. It's about having effective policies and procedures. application of modifiers, paying attention to the bundling rules. If you're utilizing non-physician practitioners, PAs, NPs in your practice, and I know they're big in urology practices, making sure that you're following the incident to billing guidelines very closely for the office, split shared services in the hospital setting, and making sure that you understand what the government is now looking at, which are called the impossible days, right? Where everything gets billed under Dr. John Lynn. And now at the end of the year, you have 18,000 RVUs under your name compared to all of your peers in urology who may have only 8,500. And the government looks at that and they say, we got you. You're committing fraud. But they don't understand the application of non-physician practitioners.
Oh my gosh, so much. I mean, each one of those topics you can spend an hour, 2 hours just talking about. I mean, what you just kind of glossed over is the nuance between the 95, 97 rules, which are still in play that you have to use when you see patients, when physicians see patients in the hospitals versus outpatient and other office and other outpatient services. The rules for those have changed in 2021, like this year, just a few months ago. You no longer need all that history and physical examination other than what's medically necessary. All those documentation bullet points, that's moot. We need to worry about medical decision making for office and other outpatient services starting January 1st, 2021. I mean, just that the nuance between those two, I mean, that's huge right there. And then definitely shared visits, split visit, as you mentioned, the 2022 proposed fee schedule for physicians by CMS is making some suggestions that they may change how split visits are going to be billed, and also possibly independent billing by PAs as permitted by states, right? Obviously.
That's
right. So many changes are happening, and you can't, for practices, you can take that and use it to your advantage, right? Instead of having this as a
absolutely
as a disadvantage or punitive, you can use this as your practice advantage. But the key is to understand the rules and know the changes, and that's why leaders are readers. You got to read. You've got to learn about these things if you want to play the game. And I completely agree with you when he said the business of medicine. And I'm going to say something that's a little controversial. The number one job of a medical practice is not to take care of patients, but to run a profitable business. Because without running a profitable business, you won't have the privilege to take care of patients. Now, that's how I used to say it, but now I say your patient's success depends on your success. That's a little bit tamer.
Yeah, look, I don't disagree with you at all. I mean, look, providers go into the practice of medicine obviously to take care of people, to restore, clinical function to an optimal level. But, you can't do that if you don't have supplies. You can't do that if you don't have a staff. You can't do that if you don't have a roof over your head. And the only way that you can have those elements of your practice is to be financially successful. And, I think part of the problem that I've seen over the course of my career is, and I mean this with no disrespect, but providers have traditionally cut financial corners. And what I mean by that is we work in an industry where people get to matriculate, right? So Sean Weiss could have started at the practice 10 years ago answering phones. And Sean's really personable, and he gets the schedules right, and he understands a modified wave schedule versus this type of schedule. And, 3 years after Sean was into practice, Jamie left the practice, and Dr. Lynn said, Sean's awesome at the front desk. I bet he'd really be good as my biller or coder. Not taking into account, Sean might not have the requisite skills to do that. But I get promoted to biller coder. Now I'm having to read, I'm having to learn. The doctor may or may not have made an appropriate financial investment in that individual to get me up to par. Now, Sean is a go-getter, and I always tell people there's two types of employees. There's those who are there for the paycheck and those who are there because it's their career. For me, I want career-minded individuals. I'm a partner in my firm. I have 9 other partners. We have I don't know, about 130 employees in our firm, if I'm not mistaken. I don't want warm bodies. I want people who want to grow. I want people who are there for a purpose. I want people who, believe in themselves because we've helped to grow them. We've helped to get them to the next level by investing in them. And unfortunately, in a lot of physician practices, people just matriculate without the requisite skills to achieve each of those next levels. The first 5 years I was in healthcare, I didn't do regulatory compliance. I was a business management consultant. So I focused really on the operations, the financial impact of provider decisions, SWOT analysis, feasibility studies, expansion, negotiating, managed care contracts. So I get it when I hear, these conversations. But yeah, if you're not financially successful, I don't care how brilliant of a clinician you are, you're never going to be successful in practice
I was just
as an independent.
Yeah, I was just in conversation with one of my very good friends last night, and we were just saying that we went to medical school together, and we were just saying that, gosh, we did not go into medicine to make money. There are other ways to make money much easier. Medicine is, I mean, it's really a calling, and you have to really love what you do. Unfortunately, I'm hearing a lot of my peers who are it was kind of tainted now because of all the payment cuts, all the administrivia, as we like to call it, all the administrative BS overhead and stuff that we have to jump through, the peer-to-peer authorizations. You have some not really qualified person just simply reading a rule book and saying, well, you don't fit the bullet points, so we're not going to let your patient have this x-ray or have this medication. So that kind of stuff is frustrating for sure. And but anyway, we did not get into this for money. If we wanted to make a lot of money, we probably gone and done something else. And I completely agree with you. And what you're probably implying is that a lot of physicians may not be the best business people. And I see it over and over again. In the type of questions that people are asking, the sophistication is simply not there. And unfortunately, we're human, and a lot of us like to just Netflix and chill, right? You want to just watch TV or not do something that can help advance your business mind or business career. And again, leaders are readers. You have to read, you have to attend conferences, you have to constantly enrich your brain so that you can play this game well.
Absolutely. Very well said. I couldn't agree with you more.
Sean, to have your name on a speed dial, how do my viewers find you?
Sure. Well, thank you so much for that opportunity to share with your viewers, your listeners. Obviously, the easiest way to find me is on LinkedIn. I have my own blog. I do podcasts every single week, which, by the way, Dr. Lin, I want to make sure I have you on, not because you had me on, but I've been following you for quite some time on LinkedIn. We've actually sat on panels together for the American Urological Association. I know we're doing that again this year for the AUA conference coming up in Las Vegas. So I definitely want to make sure I have you on the show to be able to talk about how you as a urologist have been able to be so successful in, not only building a brand, but building a business and, staying on top of all of these coding, billing, and compliance things where a lot of other providers look at it and go, that's just too complex for me. No, it's not. You're a perfect example of that. This can be done with just a little bit of effort.
And
yeah, go ahead, please. I'm sorry.
Would you tell us the name of your company?
Sure. So I am with a firm out of Knoxville, Tennessee, but we are in all 50 states and all of the territories around the country. It is called Doctors Management. You can get me very simply by calling, I'll give you my cell phone, 770-402-0855. That way you don't have to go through the 800 number and try to get them to track me down. And you could also email me at sweiss at drsmgmt.com.
Wonderful. Wow. That's the first time anyone's ever offered his or her cell phone number on air. So, I mean, talk about, I love you for that. That is so much empathy. I have done that myself at a presentation where I put my email and my cell phone number on the screen for people to take down, because you have so much empathy for people. You don't want them to jump through the hoops, and I think that is so key to a successful business.
Yeah, I'm a physician advocate first and foremost. I will tell you, a lot of insurance companies, when I get retained and they're put on notice that I'm working with them, they don't like it. I'll share with you a very quick one if I have 30 seconds.
Please.
Had a practice in the beautiful state of Hawaii reach out to me. They were audited by the big payer on the island, demanding more than $250,000 back from them.
Wow.
They got legal counsel involved. Legal counsel spoke to another attorney on the island that had worked with me. They recommended me, called me. I agreed to engage after I took a look at everything. Now, look, I turn down as many cases as I take. If it's just not a right fit, I will send it to somebody else who is more equipped or better qualified in that area than I am. I don't need to take on the cases. I've got a waiting list. But, they came out and made just such egregious accusations and allegations against this poor solo provider. More than $250,000. I jumped in, hand to God, on the same exact day that I was retained. They notified the payer on the island that I was working for the defense. General counsel of the payer called our attorney and offered an immediate 50% settlement because they didn't want to go through the hoops of arguing with me on another case. And long story short, our client wound up paying back less than $75,000 on a $250,000 demand.
All I have to say is that I'm so grateful that there are people like you on our side. That's all I have to say.
Absolutely. I've always served the providers. I will always serve the providers. Yes, I do engage with the Department of Justice and the OIG from time to time, as well as the AUSAs around the country. But most of that's in consultation. In 2017, I helped the OIG devise the study to ferret out fraud, waste, and abuse on Incident 2 and split shared services. But at the end of the day, I serve on the defense side. I'm a physician advocate, and I will always ensure due process and a level playing field for my clients.
Appreciate you so much. And you know what? You having worked on the offense side, it just makes you more valuable because, as you said, you know the playbook and you know how the other side operates. So that's awesome. And for you to be a physician advocate and to sit on the panel to help craft policy or to help shape policy is absolutely invaluable.
Thank you for that.
Sean, thank you so much for your time.
It has been my pleasure. Thank you.
All right, for those of you with any questions or comments, please feel free to leave them below. I look forward to seeing everybody again soon. Take care.